Welcome to Inside 340B Report, an insightful conversation between 340B Report's editorial team on the key issues affecting the 340B drug discount program, the nation's second largest government drug program. Hello, and welcome to the latest episode of Inside 340B Report. I'm Ted Slafsky, publisher and CEO of 340B Report, and I'm joined today by Shannon Young and Will Newton, who are associate editors and senior writers at 340B Report, and Luke Zarzecki, our national correspondent. Before we dive into the latest 340B developments, I want to let our listeners know that we're pleased to offer a special 25% discount to 340B Report first-time subscribers. You can go to the subscribe tab at 340breport.com and use the coupon code podcast25 to take advantage of the discount. I know you will find our news service to be a valuable investment. Also, I want to encourage you to check out 340B Report's business-focused podcast, 340B Leaders Upfront, hosted by Anna Mangum. The podcast showcases conversations with industry executives who are at the cutting edge of innovation and leadership in the 340B space. There's been a lot of major developments in the 340B world since our last episode. Today, we're going to discuss the latest on Capitol Hill, including reaction to a provider hearing in the House and ongoing discussions over a 2027 federal spending proposal. Major developments in the states, including a newly enacted 340B law, as well as a move by a House Speaker in another state to try to kill a 340B bill, and 340B Report's closer look at how state prescription drug affordability boards could affect 340B. First, we wanted to talk about a hearing that happened last week in the U.S. House of Representatives. For those who are not familiar with the Energy and Commerce Committee, that's the committee that usually has hearings that focus on 340B. This one was broader in scope than just 340B, but it is a committee that, as someone who spent many years advocating for providers in the program, that was always a challenge for the healthcare providers in the program, since the pharmaceutical industry is very well connected to that committee and has very close ties, particularly on the Republican side of the aisle. So that's always been a challenge for the providers. I know that we had a couple of folks that were covering that hearing. Shannon, you were the one who wrote our breaking news story on that. Can you tell us more?
Yeah, of course. So on March 18th, the House Energy and Commerce Health Subcommittee held a hearing, and it was formally titled Lowering Healthcare Costs for All Americans, an Examination of the U.S. Provider Landscape. So as Ted mentioned, it wasn't specifically focused on 340B, but it was the first time we had some providers come before the committee to talk about healthcare costs, and obviously 340B is going to come up in that type of context. And so in total, there were 6 witnesses that spoke before the panel, but just 2 really touched on 340B, the American Hospital Association President and CEO Richard Pollack, and Anthony DiGiorgio, who is a neurosurgeon and assistant professor at the University of California, San Francisco, but he noted that he was speaking in his own personal capacity. Now, both Pollack and DiGiorgio brought up 340B in their written testimony. Pollack urged Congress to, quote, oppose efforts to move 340B pricing to a rebate model and to, quote, protect the 340B program from repeated efforts to diminish its benefits to 340B hospitals and the patients and communities they serve. Now, this is noteworthy for the fact that the American Hospital Association was one of the groups that was challenging the rebate model from taking effect in Maine federal court at the end of last year. AHA was successful in that lawsuit. Even, after the Maine court ruled, it went to the first appeals court in Boston, which also upheld the ruling. So AHA has been a big player on the rebate issue and in the 340B space in the past couple months. Pollack also, during his comments to questions from committee members, touted the 340B program's importance to hospitals, including he had a pretty intense exchange with Representative Buddy Carter, who's a Georgia Republican. Carter used to chair the subcommittee before stepping down from that post to focus on his run for U.S. Senate this year. And Luke, who was there in person, will provide a little bit more of background on that exchange. But Carter, as you may remember, has been pretty outspoken on 340B in recent years. At this hearing, he stressed that he supports the drug discount program, but he, quote, wants to be what it was intended for. Meanwhile, DeGiorgio urged Congress to, quote, confront the distortions and abuses in the 340B drug pricing program and floated replacing 340B with a safety net grant in his written testimony. Now, DeGiorgio has collaborated with the drug industry-funded group Patients Rising, and he's conducted studies on behalf of the free market think tank Mercatus Center. And DeGiorgio, he told us that he receives no funding from Patients Rising or drug manufacturer organizations. But if you're wondering why his name may sound familiar, it's because we've written about him quite a bit in the past, year or so. So, Luke, do you want to tell us a little bit more on what you saw and heard happening in the committee room?
Yeah, Shannon. And as you said, I was there in the room. It wasn't the most intense hearing that I've ever been to on Capitol Hill, but it still had some fiery moments. And the subcommittee chair, Representative Morgan Griffith from Virginia, had some of the first comments on 340B since taking over for Carter. And he took more of a softer tone on the 340B program, saying that it's opaque and that a few hospitals have gone against the true intent of the program. Meanwhile, Representative Diana Harshberger from Tennessee, she asked if Congress should consider, quote, consider stronger transparency and guardrails to ensure 340B is benefiting patients. And she also noted that her and Carter introduced the 340B Access Act. So the 340B Access Act, that would make sure that community health centers can utilize multiple contract pharmacies but override state access laws. It would prohibit most hospitals' use of 340B discounts for insured patients. It would tighten hospital eligibility. It would place limits on 340B hospital patients. It would add new provider reporting requirements. And it would restrict PBM and 340B vendor fees. Now, Carter focused all of his questions on 340B, and he said he's not against 340B, but he's very passionate about it and wants to make it better. And he asked Pollack to look at the 340B Access Act. Carter was pretty passionate during his questioning, and he held up a sign from a research firm that has long criticized 340B with the sign highlighting the growth of the program. And Carter said that he would be willing to negotiate with hospitals on laws and regulations that they might want to see changed in favor of more regulations on 340B. And Rick Pollack responded to that, saying that patients benefit from 340B programs in various ways, but he'd be willing to talk with Carter about his bill.
Oh, that's interesting, Luke. I know that the AHA has been quite concerned about Buddy Carter's and Harshberger's bill. In fact, they have issued a report that says that 75% of urban-based hospitals would lose eligibility if this 340B Access Act went into law. So I'm not sure they're going to be these discussions, or if they occur, will be particularly productive. But it's interesting that they had that dialogue.
Yeah, we will have to see as time moves forward. And after the hearing, hospital groups responded and said that the 340B is working as it is intended.
Luke, did any other hospital groups respond to this at all, including AHA's comments or Carter's comments?
Yeah, so America's Essential Hospitals, they mirrored a lot of what the American Hospital Association had said, and they pointed to pharmaceutical manufacturer misinformation and mischaracterization of the program and said that the program is working as it was intended. Health center groups were a little bit more nuanced, and even though they opposed Carter and Harshberger's bill, the Advocates for Community Health said that they would be willing to work with Carter and said that the organization is focused on ensuring the program is working better to access care. And the National Association of Community Health Centers said that health centers are model stewards of the 340B program, and they would be interested in working with the committee to ensure access to the program.
It's super interesting, Luke, and great job getting all of these perspectives there. It's really important to see what these different trade groups have to say as lobbying is really heating up in Capitol Hill. And speaking of which, another trade group, a hospital trade group, 340B Health, is actually holding their lobby days on Capitol Hill as we speak, March 25th and March 26th. So I'm sure they are actively working as well on areas like 340B rebates, preventing them, and other areas of interest. And then I know elsewhere on Capitol Hill, there's some very important ongoing discussions about federal funding. So, Shannon, could you tell us a little bit more about that?
Yeah, of course, Will. So right now in Washington, it is appropriation season. And starting in the House, where spending bills originate, the House Appropriations Committee, which oversees federal spending, is accepting members' funding requests on health-related community projects. So that's for specific programs and activities, as well as bill or report language that doesn't include direct funding. And that's through March 27th. So again, we're recording this on March 26th. By the time this airs, those requests will have to be in. The Senate Appropriations Committee is also starting to accept senators' federal funding requests through April 21st. Now, this is for the fiscal year 2027 budget, and it would specifically be for the portion of the budget that oversees the healthcare agencies. If you remember, there's several spending bills that lawmakers work through that deal with different agencies. So these are the timelines right now that for the LHHS funding, which is for the labor and health and human services and education related agencies. So if you remember from a couple months ago, the fiscal year 2026 budget was approved and signed into law in February. So we're still a long ways out on the fiscal year 2027 bill and what will be included in that. President Donald Trump has yet to release his budget proposal as of today of this recording. It was due in early February, but the White House is reportedly planning to release that proposal in late March, early April, potentially next week. However, that timeline could be delayed due to the ongoing federal shutdown for the Department of Homeland Security and the U.S. war with Iran, which are kind of complicating things in Washington and tying up lawmakers on Capitol Hill. You know, we're still waiting to see what could show up in a potential HHS budget in fiscal year 2027, which begins in October. But one thing that we have been hearing is that there is a bipartisan group of lawmakers who is circulating a letter to include language in the LHHS spending bill in the House that would block the 340B rebate model implementation. So this group includes Representative Doris Matsui, a Democrat from California, and Dusty Johnson, who's a Republican from South Dakota. They've been active on other 340B related issues in the House, so it's not too surprising that they're looking at this language. And also, when lawmakers were working to wrap up the fiscal year 2026 spending bill, there was language that came out in those talks about requiring HRSA to report to Congress on 340B rebates. We haven't heard any updates on where things stand with that, but it is something that lawmakers have expressed concerns about in the past couple months. And so I wouldn't be too surprised if we saw this show up in the bill. However, we still are waiting on that bill and what Trump's going to include in his proposal.
Before we continue, let's take a moment to hear from one of our great sponsors.
The rebate pause didn't remove risk. It raised the stakes. As manufacturers expand data demands and tighten controls, pricing integrity has become the first line of defense for 340B programs. Proximity treats pricing as a living system, monitoring every claim to surface silent pricing failures before savings are lost. A mid-size FQHC using Proximity typically sees a 16x return from identified pricing errors alone. To learn more, reach out to hello@proximityhealth.com. That's hello@proximityhealth.com.
Will, it's been quite a busy week in the world of state 340B action. I know you've been very busy, particularly following developments in the West Coast as well as in Middle America. Can you tell us a little bit more about some of these interesting developments and sort of the tale of two states, it looks like? At least those are the two big ones that you've been following.
Yeah, definitely. It has been a very hectic past couple of weeks in the States. And about 3 months into 2026, we have finally had our first major 340B law passed in a state. And that happened on the West Coast in Washington State, where Governor Bob Ferguson signed a bill on March 25th, signed a big 340B bill in the state capitol in a signing ceremony where he was surrounded by a number of providers in the state. And what that bill would do is a number of things, but it would prohibit drug manufacturers from restricting the delivery of 340B drugs to contract pharmacies. So with that law in place, Washington is now the 22nd state in the country with a 340B contract pharmacy access law. It would also prohibit manufacturers from conditioning access on claims data requirements that are not already required under federal law. So a number of the 22 contract pharmacy access laws also have these provisions in them explicitly. This is becoming pretty important now, particularly as we're seeing more and more manufacturers implement policies that would require covered entities to report more claims data, including now in some cases in the in-house pharmacy setting. And I know that's something that we discussed in quite a bit of detail our last episode. And the other really interesting thing this bill would do is require both 340B providers and manufacturers to report new information about their 340B program participation. And this is the first state, as far as we know, that is actually pairing manufacturer reporting requirements alongside provider reporting requirements. We have seen a number of states implement provider reporting requirements. Minnesota, of course, which we discussed in our last episode, being the most prominent one there. And so that's another pretty interesting component of this bill. This bill, throughout the legislative process, though, had strong opposition from drug manufacturers, and they wasted no time in filing lawsuits. Actually, the exact same day the law was signed by the governor, two manufacturers, AbbVie and Novartis, both filed federal lawsuits challenging the law, arguing that the contract pharmacy restrictions are unconstitutional, that they are preempted by the federal 340B statute. And then one pretty interesting thing as well is that in AbbVie's lawsuit, I noticed that the manufacturer also argued that the manufacturer reporting requirements were unconstitutional because they violated AbbVie's right to free speech. So that's sort of an interesting tidbit there. We've seen there's been a lot of support among manufacturers for placing more reporting requirements on covered entities. So it's certainly interesting to see that when there is reporting requirements on manufacturers, there is some objections from AbbVie. Should also note, though, that AbbVie is not a member of PhRMA, the trade group, and PhRMA has been kind of the one leading the charge on pushing for covered entity reporting requirements. So either way, still a pretty interesting development there. Then, as Ted mentioned, what happened in Washington was very, very different than what happened in Kansas in the Midwest. And even though, this is the first major 340B bill that got passed in Washington, we definitely still have seen a lot of really interesting action happen in other states. And what happened in Kansas was really pretty remarkable. And so for some context, back last March, the Kansas Senate passed a bipartisan contract pharmacy access bill by a 34-6 margin, pretty wide margin. That was supposed to strengthen the state's existing law because that law couldn't really be enforced and also is going to expire this summer. So that one passed pretty overwhelmingly. And then it went to the House, where it basically a year later never got any committee hearing, never got any committee vote. And the Speaker of the House in Kansas, Dan Hawkins, he had been basically moving the bill back and forth and preventing a vote. Then what happened was about a week or so ago, there was some movement. There's a big group of Kansas Republicans, as well as some Kansas Democrats, Kansas Speaker of the House also being a Republican. But these Republicans were basically going to pull this maneuver to force there to be a debate on the contract pharmacy access bill because the speaker had refused to bring it to the floor. And then in response to that, the speaker basically just ended the session early and sent all of the lawmakers home. This, of course, is very controversial. There are a lot of politicians in Kansas, even from his own party, that were very upset about this. We had a pretty interesting conversation with Kansas State Senator Mike Murphy, who is very opposed to this. Providers in the state were very upset as well. And so it looks like this bill, unless he brings the Kansas House back into session, is not going to see a vote. Although, there is always a chance he could reverse course if there's enough pressure. And I should also add that this is the second pretty high profile time that there is sort of an inter-party rebellion against Kansas House Speaker Dan Hawkins. He had been a proponent of a mid-decade redistricting in Kansas, but and wanted to call a special session to get that done. But enough members of his own party ended up defecting and voting against calling that. So Kansas was unable to push forward the mid-decade redistricting effort that Hawkins had wanted. So long story short, it's been a pretty wild ride in the States, I would say.
Yeah, I would say so. Well, thanks for covering all of the developments there. I'm sure you'll be keeping your eye on them as we move towards the close of those legislative sessions and others. Wanted to ask you, though, about legal developments in the state. Obviously, we're also tracking a lot of court actions going on involving 340B bills. What's the latest there that you've been watching?
Right. So I mentioned earlier that AbbVie and Novartis had both sued Washington's law. All of the other 21 contract pharmacy access laws have also faced multiple drug manufacturer legal challenges, and we're starting to see more and more results kind of trickle in there. And the two biggest results we've seen recently were that a federal district judge in Tennessee dismissed AbbVie's lawsuit challenging that state's law. Tennessee's law is pretty unique in that it allowed existing manufacturer contract pharmacy restrictions to stay in place, but prohibited new ones. It also prohibits manufacturers from requiring claims data that's not required under federal law. So that's certainly a big one there. Sorry, I should say it was actually the Tennessee federal district judge had already dismissed AbbVie's lawsuit, but this week additionally dismissed Pharma's lawsuit challenging the same law. So same thing there. And then the other big development recently is that a Colorado federal district judge recently denied Pharma's motion to block enforcement of that law. That is the third time now that a drug manufacturer motion to block Colorado's law has been denied. Pharma immediately appealed that to the 10th Circuit Court of Appeals, where there are a number of other ongoing challenges. So that's another development that we'll be really closely watching. But I would say, as far as kind of the big picture for kind of understanding what's happening here, is that the most important cases now are going to be the federal appeals court cases. And most federal district courts have sided with the states, with the exception of West Virginia and Oklahoma. And at the appeals court level, where most of these cases are at this point, 2 federal appeals courts have sided with the states, the only 2 that have issued rulings so far, and the rest are ongoing. And so it'll be really, really interesting to follow these cases, see what happens at the federal appeals court level, because if we see a federal appeals court issue a different decision, then that's when the likelihood increases that potentially the Supreme Court could take up this issue. So we're really closely following that as well. And then I know another pretty interesting thing that's happening in the states are a number of state legislatures have been implementing prescription drug affordability boards. It's a pretty new development that also has some pretty interesting 340B implications as well. Luke, you did a really good job, did a very cool closer look, really diving into these boards and specifically how they could impact the 340B program. So I'd love to hear a little bit more about that.
Yeah, so PDABs, or prescription drug affordability boards, have been popping up in states across the country, with Maryland and Colorado furthest along in the process of placing an upper payment limit on drugs within the state. And essentially what these boards do is that they consider the affordability of certain drugs within the state that are either posing affordability challenges to the state in general, or in particular to patients. And then these boards decide whether or not to implement an upper payment limit, which is the most an organization can pay for a drug within the state. Now, outside of 340B, groups have argued that a PDAB will save money, while others say that it will impact the drug supply chain and have unintended consequences. And I spoke to a number of sources about a PDAB's impacts on 340B. And a few had said that it will reduce revenue from 340B drugs. It will have implementation challenges. It may incentivize drug makers to stop selling a drug within a state. And in some states, like in Maryland, that are attempting to carve out 340B drugs from any upper payment limit they may place within the state, that could reverse and actually incentivize insurers to not cover 340B drugs, since they would see a cheaper price for a drug that is not 340B in comparison to a drug that is 340B because of the carve out. And one state did a report on the PDAB in general, and they kind of talked about its impacts on 340B. And many providers that were involved within the report said that it could potentially erode 340B savings.
Yeah, that's interesting, Luke. It's sort of in some way analogous to what's going on with the Medicare negotiations and some of the other negotiations that the Trump administration is doing with the drug companies, while everyone embraces the idea of lower prices, and that's a good thing. It also does mean potentially reductions in reimbursement and reductions in savings for the 340B providers. This has happened a lot with the changes in wholesale acquisition cost on a number of drug products, and that has resulted in a significant loss of margins for the providers of the program. So this will be one to keep an eye on to see if these PDABs, first of all, whether they're effective, and second, whether they will have an impact on 340B, or whether the 340B providers will be successful in getting an exemption from the program. So good work on that deep dive. I know you worked hard on it, and congratulations on your article.
Thanks. And an interesting point you brought up was the Medicare maximum fair prices. And some of the PDABs do use that number when they're considering drugs. So kind of a inadvertently collaboration between the federal and state governments.
Right. And the PDABs would be not just focused on the Medicare population. It would be other patients in the state that have affordability challenges. Is that right?
Yeah, and it really depends about how the Prescription Drug Affordability Board statute was written. Some impact all the drugs within the state, some impact commercial plans, some impact state employer plans. It really kind of just depends, and all the bills are written differently.
Okay, well, great job there. Well, I think that's it for today. I know we covered a lot in today's podcast, and we'll be continuing to keep an eye on all things 340B related, and be back in 2 weeks with a new episode. Of course, we will report on anything that happens in the meantime on our website, 340breport.com. Please follow along too with our twice weekly newsletters. And just a friendly reminder, if you're not currently a subscriber, you can take advantage of our 25% discount for first-time subscribers only by going to 340breport.com, clicking the subscribe button, and using the discount code podcast25. Thank you for joining us, and we look forward to talking to you in 2 weeks.